fresh episode on our academic program on obesity management, which is hosted by Dr. Lexus along with Center for Metabolic Surgery. This institute is headed by Dr. Raman Goyal and is one of India's top bariatric surgery center. So today we will be discussing the role of bariatric surgery in obesity. In addition to diet modifications and daily exercise, bariatric surgery serves as a minimally invasive approach to control diabetes. Furthermore, recent advancements in bariatric surgery have helped improve patient outcomes. And considering the increased prevalence of diabetes in the Indian population, which affects almost 77 million individuals, having detailed knowledge of various strategies to manage diabetes is crucial. To throw more light on this, we have our guest speaker for today, Dr. Rushin Mehta. Dr. Rushin Mehta is a physician and diabetologist with an experience of more than 7 years now. After completing his MBBS from DY Patil Medical College and Hospital, Mumbai, he has completed his his diabetes course from Cardiff University, UK in 2012, and then he's also taken a certificate course in management of diabetes from Public Health Foundation of India. He is currently associated with Sir H.N. Reliance Hospital, Breach Candy Hospital, and Wokhart Hospital, Mumbai. He has been lecturing in various international and national conferences and is also a physician in various parts of UAE. It's a pleasure to have you on board, Doctor. I would now request you to please start your presentation.
Good evening. Thank you very much for the wonderful introduction. My name is Dr. Rushin Mehta, and I'm a physician and diabetes specialist. I am attached to Sir H.N. Reliance Hospital Foundation, Beach Candy Hospital, and Wokhart Hospital. Today, we have a great topic we're going to have a discussion upon. A simple and a very known subject, but something we're going to go in a bit detail about the simplicity of diabetes and bariatric surgery, where I like to call it diabesity. Most of us are very aware of the causes of diabetes. One of the most commonest causes is genetics, then obesity by itself, poor lifestyle, which is bad exercise, poor eating habits, eating all the amazing things without the repercussions of the similar problem, excessive stress. One of the biggest problems in the last 2 years has been excessive stress, good and bad. Pregnancy by itself, one of the leading causes of diabetes, drugs itself, and of course, diseases, multiple diseases which lead to developing hypoglycemia, which can lead to diabetes as well. Is one of the other causes of diabetes. So let's look at obesity and diabetes in a major aspect. We all are aware that diabetes is one of the leading causes of death in this world. And one of the leading causes of diabetes is obesity by itself. India is, as you all know, the second largest obese country with next to the highest number of diabetics. Very importantly, you need to understand why is obesity so important to be looked upon in controlling of diabetes. Because with every 10 kilogram body weight loss, there is a 12% rise. With every 10 kilogram body weight gain, there's a 12% rise in the chance of ischemic heart disease. Now, this is a very big number. In a population of 1.3 billion people, if everyone just starts gaining 10 kilos of weight and more, we can imagine that our cardiovascular friends are super going to be trigger happy. 80 to 85% of obese people will end up with type 2 diabetes. And this is a huge burden economically, socially, and on us as medical and paramedic staff to handle such a crisis, which is near almost bigger than a pandemic by. So we keep on discussing obesity, but what is the major pathogenesis of obesity? And why is it so important to be catching our patients early in the game? So pathogenesis of obesity with diabetes is a high BMI with a high waist-hip ratio are directly linked with insulin resistance. Primarily, this is the most important chain, the most important key to the chain, which is insulin resistance. A lot of our patients who are obese, they walk into our clinics with a requirement of a weight loss. And you might have seen many of your patients find it very difficult to lose weight. And even if they're trying, they say, doctor, we are exercising, we are dieting, we are doing everything under the sun, but somehow we are not able to lose weight. And then you realize that these people have a very important key to the chain, which is insulin resistance. So the biggest pathogenesis is insulin resistance. The production of non-esterified fatty acids, which is NEFA, from the adipose tissues of obese individuals is the cause of this insulin resistance primarily. So insulin resistance with beta cell dysfunction is again the leading cause of type 2 diabetes. Visceral fat is more resistant to the lipolytic action of insulin than that of the subcutaneous fat. So all in all this leads to something called as insulin resistance, leading to then diabetes. I always give my patients a very simple example. It might sound crude, but it is apt. Now, if you're living in a two-bedroom hall kitchen and you ask them that you want to control your weight, you are living in a two-bedroom hall kitchen, you have one person to clean it up. He does a fantastic job. Suddenly you move to a four-bedroom and a six-bedroom and an eight-bedroom hall kitchen, and if you give the same guy to do the same job, he's going to falter. And that is going to eventually lead to a lot of dust accumulation, and eventually it's going to be health breaks loose. So that is how insulin resistance develops, with the fat excessively growing up into the subcutaneous and the adipose tissue, into the visceral fat, which then allows the weight gain to continuously keep on happening, and which will prevent the insulin to act on it to control the sugars, and also the important insulin therapies on the fat cells, which then eventually will lead to diabetes, because the insulin will get overworked and it will fail, and the beta cell dysfunction will take place, leading to diabetes. So one of the many options of treatment will come down to your most common is your weight loss, your diet restriction, exercising, and eventually the medication, which is your OHAs, and insulin therapy, and then there's a surgical option. So let's look at that in a better limelight today. Pediatric surgery and its impact on diabetes. The first thing is any amount of weight loss is known to cause a reduction in type 2 diabetes, and in some cases, it's almost completely reversible. Now, in bariatric surgery, the bariatric surgery commonly is taken up in a person who is diabetic and obese. Of course, Dr. Raman Goel sir and his team is going to explain to you all the definitions of who is the right candidate. But in a diabetes patient, we commonly would see that a person who has either a long-standing diabetes not under control, or even a short-acting diabetes who is with excessive obesity would be the right candidate. In bariatric surgeries, we have two options which you're all aware of. One is called gastric restrictive surgeries, which is a laparoscopic gastric banding surgery, sleeve gastrectomy, etc. And you have the intestinal bypass surgery, which is the gastric bypass surgery, which is a Roux-en-Y, and then the Bilio pancreatic diversion as well. Now, when we see weight loss with any bariatric surgery, what is the pathophysiology of diabetes control? So the weight loss by bariatric surgery is almost more than 50 to 20% of the body's weight, which is significantly higher than any conventional weight loss therapies you might have seen. All the pro-inflammatory markers which are produced from the adipose tissue, which is your interleukin 6, your IL-1, your TNF alpha, your homocysteine, your insulin resistance factors, CRP, the HSCRP as we call it, all of them are significantly reduced, causing reduction in hence insulin resistance. And forced and consistent restriction of diet, along with malabsorption, would lead to a higher yield. And that's how, when you have a great amount of weight loss happening over a period of time, which is then sustainable for a longer period of time, the chance of you developing further diabetes reduces, the chance of you controlling your diabetes or even reversing to a great extent will always increase. Now, what is the hypothesis? Now, you may argue that there are some people who, just by weight gain, why would it be a better way to reverse the diabetes than actually losing it on your own? So let's look at the hypotheses on bariatric surgery causing weight loss, leading to the diabetes reversal. So weight loss causing increased insulin sensitivity is one of the markers. The second is less lipotoxicity and increase and inflammation is reduced, and the gut hormone changes. If you can clearly see, we are discussing about a couple of we're talking about a couple of hormones here. Now, one of the most important thing is in a bariatric surgery. This is a classical Roux-en-Y bariatric surgery, which you are seeing on the side, and you can clearly see all the areas where different peptides and hormones are working for a great weight loss in a patient, also leading to reduced diabetes and probably a reversal. So the first thing, which is a restrictive pouch, which is controlled on top, which is created, which will obviously reduce the intake of food. The passage of food will become distilled into the small intestine, is always accelerated. Then the hormone, which is called the ghrelin hormone, which is secreted from the stomach and the fundus, which stimulates the appetite. They will obviously reduce, and the appetite and everything will go down, and the satiety will increase. Then food, which will no longer travel through the duodenum and get bypassed, so some amount of malabsorption of fat will occur. Then the peptide YY, which is secreted in the distal small intestine, will which is in response to the food, will induce the satiety. So the moment it reaches the distal end of the small intestine, it informs the brain that we already received food, so we will get satiety faster. The glucose-dependent insulin-tropic peptide, which is a GIP, and then the GLP, which is glucagon-like peptide, they get secreted, and they also lead to reduction of they increase the insulin production. They also reduce the glucagon production, and they're also going to be giving you satiety, bloating, a reduction in digestion of food, better peripheral usage of your sugars, etc., in a much better manner, which also improves satiety. And then eventually, the food and the digestive enzymes will get mixed downwards, and then intestinal gluconeogenesis will be increased. So this in all is how our gut hormones will contribute into the weight loss reduction or weight loss increasing, sorry, and also the diabetes reversal in a patient with all the hormones. So let's look at all the three types of bariatric surgeries and its outcomes on diabetes patients. So if you have a person who's undergone a laparoscopic adjustable gastric banding surgery, the weight loss is approximately a 46.2% weight loss. The operative mortality, of course, is only 0.1%. Remission of type 2 diabetes mellitus in these people is around approximately 56%, and remission of hyperlipidemia is around 59%. So whereas in a Roux-en-Y bypass, gastric bypass surgery, you can clearly see that the operative mortality slightly increased from 0.1 to 0.5. Dr. Goel sir can obviously give us guidance on that. But most importantly, the remission of type 2 diabetes mellitus is almost 80%. And the remission of hyperlipidemia is almost 97%. For the biliopancreatic diversion, if you can see, there's a higher slight mortality than any of these procedures. And the malabsorption is always higher in a biliopancreatic diversion, but the remission is almost 95% of diabetes and almost 99% of hyperlipidemia. So you can clearly see that the favorable options for a bariatric surgery in a diabetic patient, of course, would be a possibility of a Roux-en-Y or a biliopancreatic, but Roux-en-Y more commonly done. Now, the impact on diabetes reversals and diabetes controlling and reduction in post-bariatric surgeries have been seen by multiple studies, which includes the Swedish obese subject study, which is a SOS study, the Schwauer et al. Study, and the Tories et al. Study. And all of them together are landmark trials of more than 3,000 patients in each separately, showing them over a period of time with various different levels of diabetics having different levels of diabetes in their system, have been shown that a great reduction and reversal in type 2 diabetes in both short and long-standing diabetics, specifically with the Roux-en-Y surgery with a sustainable weight loss. And the requirement of insulin has reduced or almost become nil in most patients who have undergone this treatment. Now, another slide I would like to discuss with you between the three arms of laparoscopic gastric banding, the Roux-en-Y and the biliopancreatic diversion. The tempo of diabetes remission in an adjustable banding is a slower level, whereas the Roux-en-Y is a rapid, and so is biliopancreatic diversion. The insulin sensitivity is improved in both the Roux-en-Y and the laparoscopic adjustable banding, but in biliopancreatic diversion, it's almost supranormal. The insulin secretion is reduced in your laparoscopic banding, whereas it's increased with the Roux-en-Y, and it's reduced again in the biliopancreatic diversion. The glucagon-like peptides has no change in the laparoscopic adjustment, laparoscopic gastric banding, let's call it, and there is an increase in the glucagon-like peptides in the Roux-en-Y and in the biliopancreatic diversion. The peptides YY have no change in the laparoscopic adjustable gastric banding, whereas they increase in the Roux-en-Y, they increase in the biliopancreatic diversion, and the glucose-dependent toxicity has no change or reduced in all three of them. This clearly suggests that the possibility of bariatric surgery causing a weight loss and a diabetes conversion and a reversal is much higher with the Roux-en-Y as compared to a gastric banding surgery. Now let's look at a bit of a long-term side effects. Now most of us always talk about, okay, we've understood that bariatric surgery will help you. So what about the long term? So we have seen that prolonged control of diabetes with a Roux-en-Y bypass has been observed cross-sectionally with multiple RCTs. A micro and macrovascular both complications have shown a reduction of approximate 20% overall in type 2 diabetics over many, many years with sustainability. Malabsorption has to be tackled with good nutrition management and psychological training primarily, but these are going to be in the favorment of your diabetes management in a patient with type 2 diabetes mellitus, in a bariatric management in a patient with type 2 diabetes mellitus. These would be great positives in your patient to help you reduce it. So I would like to conclude this in multiple ways, is that diabesity is a leading problem in this world. We need ourselves to be geared up in a multiple way to control our weight in all our patients and allow them to reduce their weight with exercise and diet. But also importantly, we should not negate the fact that a bariatric surgery option is always available, because not only just controlling the sugar is important, but even there's a high chance of reversibility as well, as I've clearly shown. Thank you for patient listening, and I'm happy to answer any questions. Thank you.
What follow-up data should a physician take from the patient who has undergone a bariatric procedure? What would be the point of concerns that a physician needs to address?
Thank you for asking that question. So one of the primary things which we need to look at is insulin and insulin resistance in a patient with a diabetes patient, in a post-bariatric surgery patient, in a long-term follow-up. So one of the key parameters to look out is the fasting insulin, the postprandial insulin, the fasting C-peptide primarily, and also you need to look out for your microvascular complications, which is your urinary albumin-creatinine ratio. You also need to do a retinal checkup on a regular basis. These are the few parameters which will guide you on the long-term preventive lookout on the diabetes and the reversal of the diabetes on a whole side. The other are the pro-inflammatory markers as a physician would like to keep a track on, would be the HSCRP, the homocysteine values, the interleukin 1 and interleukin 6. If they are able to do those tests, it would be great to have in the chart. But at least the primary HSCRP and the homocysteine would give us a great understanding on the pro-inflammatory state of this patient, and then allow us to take care of the prevention of ischemic heart disease and strokes. The other parameters, of course, would be the liver function enzymes, and you would also like to look at the lipid profile, which you will want to see, because hyperlipidemia is also reversed in multiple ways. The other ones which Dr. Goel would really emphasize on is the vitamin deficiencies due to malabsorptions of multiple of these surgeries, which are need to be looked at: your iron, your B12, your folic acids, and your vitamin D3. And in a nutshell, these would be the parameters you would look for. Thank you.
So the question was that, is there a change in life expectancy after bariatric surgery?
So the exact percentage in any RCTs, I am not exactly aware of, but I would 100% say that with the help of reversal of diabetes, with the help of reversing obesity into a reduction, into becoming actually much more smaller in size, would allow you to have a much more higher life expectancy, as your pro-inflammatory markers would reduce, your hormonal imbalances would get corrected, your entire physical being would improve because of the weight on the knees, the weight on the ankles, the weight on the back would reduce considerably. Your exercise regimen would improve. Your lung capacity would improve, allowing you to breathe much better. So, on a whole, a bariatric surgery for an obese patient is excellently well coordinated, as long as you maintain the guidelines given by your surgeon, allowing you to follow up on a regular basis, very importantly, and allowing your malabsorption not to get the better of you. The life expectancy, in my opinion, would increase multiple ways. The percentage, actually, I would leave it to Dr. Goel to guide us on. Thank you.
Thank you, Dr. Rushan. Thank you so much. And Dr. Raman, do you have any questions for Dr. Rushan?
So, Roshan, yeah, since
Sir.
you're managing primarily the diabetes patients medically,
Yes.
when do you take a call to refer a patient to a bariatric surgeon? Is there any guideline
Is there any criteria?
by the physicians or in your own when you decide? I'm not talking of morbidly obese people.
Right.
Somebody who is, let's say, 31 BMI and is under your treatment, and at what stage you realize that this patient will do better with surgery than with long-term medicines?
So it's a great question. There is no immediate guidelines on this gray zone, which I'm aware of, which is a part of our regular checkup. But in my opinion, I've had actually two people who are BMI of 32, in fact, who were diabetics, who have undergone bariatric surgery, and till today, both are doing excellently well. One, of course, was done by you only. In these patients, I've noticed that when you have a person who has insulin resistance primarily, which is on a significant higher zone, and the patient is motivated enough to have a weight loss induced life, but he needs a seed money. For any business, you need seed money. If you need the position to put yourself in, and if you're getting any comorbid illnesses, which is not only just obesity, but if you have insulin resistance, type 2 diabetes, if you have hypertension, bariatric surgery would absolutely make a huge difference. Try and catch your patients if they're early into the disease, more than catching a morbidly obese people who's late into the disease. Of course, they're going to do well, but that is not going to be. That's already at a huge cost of a life that he or she has spent, which has not been comfortable for them. So catching them late into the diabetic forum to get them a bariatric surgery done is not greatly appreciable, because then the value of the insulin reduction, of the dose reduction, and the OHA reduction dosage do not really make a huge difference. So you need to look at your patient in a whole, in total. I have had two patients who have undergone bariatric surgeries very recently, towards the later part of the diabetics. They've been diabetics for more than 10 to 12 years. And I have noticed that their reduction of insulin was there, but it was not as much as what I've done in a younger diabetic patient. I would not say younger by age, but I would say younger by the number of years in diabetes. Their reduction and the prolongation of their diabetes has been longer. So, coming in a nutshell, what Dr. Goel is trying to ask, and my clear request to him would be to throw more light to us if there's something which we are missing. But I would put it that a younger person into insulin resistance, not younger by age, sorry, younger in the number of years in the disease of comorbidities, would, if he or she has younger diabetic or younger insulin resistance patient with other comorbidities, maybe like blood pressure or cholesterol, if he or she is a 30 to 35 BMI who is in the gray zone, should be considered on a bariatric surgery. If they are also motivated enough to then be part of the cycle in trying to maintain their weight and malabsorption and vitamin deficiencies, etc., on a long term, they would be a great candidate to push over for surgery, because in the long term, effects on insulin resistance and all the pro-inflammatory markers will be much lesser. The micro and the macrovascular complications are reducing, as I clearly showed, in a great extent, almost 20% over a period of years, and sustainable by multiple RCT studies. So that would be, in a nutshell, the guidelines would be.
To say is that that patient should be referred early rather than late.
Yes, yes.
So,
Earlier into the
yeah.
disease is much better than later.
Okay,
Absolutely.
fair enough. And what is, I mean, you have seen patients, you are in Mumbai, you have seen bariatric patients who have surgeries few years back, your patient or other doctors' patients.
Yes.
What do you see as the quality of life in these patients? Is it are they happy with their for when they come for follow-ups for different things? Need not be diabetes alone. So
Sure.
when they are coming for a diabetic who had a bariatric surgery, when they come back to you after 4 or 5 years, are they comfortable with it, or are they not happy about it? What do you feel compared to medical management? I'm just trying to say, I want to know the quality of life issues.
So, sir, to be very honest, there's slight of a mixed picture here. I won't say it's a clear-cut, absolute, happy, smiley, fancy face. See, any BMI person who is more than 40, 45, they are on top of the world because they reduce their weight considerably well. They come down to a BMI of 30, 32, which they've never dreamt in their lives. And then they start looking and feeling much more better. And they're happy to do the regular follow-up. So there's a big chunk of those patients. I have a patient who's come, who is my mascot for bariatric surgery. This gentleman is a 58-year-old now. He did when he was 52, 6 years ago. No, sorry, 8 years ago, so when he was 50. He, till today, loves his bariatric surgery. The way he's been able to wrap his head around the weight loss and the way he's been gung-ho about his looks, his style, his entire business personality, the way he's been able to conduct his business, he's been much more. He was an introvert, became an extrovert, and a lot of other things, psychologically made a difference. In fact, you won't believe he got his 24-year-old daughter also to come in and do a checkup, but of course we told her, no, wait, you probably might need a few years. So he has been referring patients to reference center. So there are patients who are extremely, excessively happy. There are some, especially I've seen sometimes in abandoning surgeries, that they do feel that their weight gain has come back slightly back. So if you lost 30 to 40 kilos, you would gain back 15 to 20 kilos. And then they feel that, oh, then I was taking 5 tablets, now I'm down to only 3, so it's hardly I've only lost 2. But I always tell them that it's because of you have not been able to do good by the surgery. See, surgery is not a magic wand which you just take and wave it around and then get absolutely back to normal or back to athletic form. That's not going to happen. You need to work towards it. And most of them, whoever are unhappy, are because they don't work towards it. So one of those is the major concerns, and a slight unhappiness always is around the food intake, because people who used to eat 3 chapatis suddenly come down to half a chapati. Their non-vegetarian options reduced to smaller quantities. So that's always a bit of a tiff. But I think with great counseling and great explanations, the nutritionists can turn them around, and then they do feel more comfortable and much more happier. I had a recent lady who had no comorbidity illnesses at all. She had zero, no diabetes, no blood pressure, nothing. But her obesity was her biggest bane. She was a successful entrepreneur, successful she was a businesswoman with entrepreneur and doing various multiple things, but always was shy about her weight. Boom, weight loss, come down. She is on top of the world. She's right now even running much more things than she could. So you see both sides, and she's already been 2.5, 3 years into the bariatric study.
Yeah, I think thank you so much, Dr. Roshan. That was wonderful. People should see the both sides of the coin and then only take a decision. Thank you for highlighting that. Yeah. Thank you so much,
Thank you so much, sir.
for a long time.
Thank you for the opportunity, sir, for this. I really appreciate it.
Thank you so much.
We are honored, Dr. Rushan. Thank you for the time. Thank you so much.
Thank you so much for your time.
And we will keep you posted if we have more questions. Beautiful lecture, isn't it, Dr. Raman?
Absolutely.
Very nice, very nicely done. So I would request you now to take over with your part.
Okay. So good evening, everyone. This is probably the most important talk of the topic that we are going to cover, because when we started doing bariatric surgery in 2000, almost 21 years back, we were talking only about treatment of weight. So we were basically a weight loss surgeon, and many people confused us with cosmetic surgeons. But somewhere in 2004, studies started appearing saying that bariatric surgery individually and directly treat diabetes. And initially, there was a lot of disbelief about it because everybody thought that how can you claim that diabetes can be surgically treated, because for generations it has been only medically managed. And thus, this has been a major transformation. And now so much evidence has come that people have accepted, physicians have accepted, American Diabetes Association has accepted that diabetes can be surgically treated. And there are various guidelines and indications that I'm going to talk in a short time of 5 to 7 minutes with you. And Dr. Rushin has very nicely briefed us about various mechanisms and how bariatric surgery works in terms of diabetes control. So, important thing to realize is that diabetes is not only a lifestyle problem; it's a lifelong problem. And that is how people used to say that diabetes is a Raj Rog. Once you have a diabetes, you always have diabetes. And gradually, all patients end up having more and more medicines. And despite that, almost 56% of patients worldwide remain uncontrolled diabetics, even though there are so many good medicines. And then when they remain uncontrolled, they end up with diabetes-related complications, which could be anything from myocardial infarction to brain stroke to renal failure, you know all of them. And this is important to realize that why surgery should be even considered, because there's a huge chunk of patients who do not respond to medicine or who are not able to change their lifestyle. This gentleman who had come from Kenya was on high dose insulin when he came to us. And within a short time, he not only lost weight, he stopped all medicines for diabetes and maintained his blood sugar for a long time. Now, we all know that diabetes is closely associated with obesity, to the tune that Dr. Rushin called it Diabesity, which is an accepted term. So diabetes and obesity works together. And bariatric surgery is now accepted treatment for obesity and diabetes both. When both of them are there, then obviously it helps. But even if somebody has only diabetes, then also surgically diabetes can be treated without significant weight loss. So we are going to talk a little bit about that. Before we go there, let's see how do we define remission of diabetes? So there is a partial remission, that if somebody has a glycemia, that means HbA1c between 5.7 to 6.4, and is not taking any medicine for diabetes, then it is called partial remission if this is there for more than 1 year. Now, complete remission is if the HbA1c is below 5.7 for more than 1 year. So that means the HbA1c is the criteria along with the 1 year. And if the complete remission, that means if HbA1c is maintained below 5.7 for 5 years or more without any medicine, then it's called prolonged remission. Now, these kind of definitions are not there for medical management because we do not achieve this, but surgically it is possible to achieve most of these, and I'll show you how frequently surgery gives a remission from diabetes. Dr. Rushin spoke about various mechanisms, a brief slide, single slide on this, to show that there are various mechanisms. Like just by restricting the diet and the calorie intake, sugars do improve. So surgery also works through restricting the calories initially. Then there is a foregut hypothesis that if food doesn't go through the duodenum, then insulin resistance doesn't happen. And if that doesn't happen, that automatically diabetes improves. Then there is a hindgut hypothesis, or what is called as a GLP-1, that if food reaches terminal part of the intestine faster, then GLP-1 hormone is secreted from ileum, and that causes blood sugar control. Then there are changes in enterohepatic circulation, or the bile acid circulation in the blood increases, and that is believed to control blood sugar. Then there is a change in the gut bacteria. The healthier bacteria are seen, which so a lot of people believe now that gut bacteria are responsible for obesity, gut bacteria are responsible for diabetes, so many diseases. So it is seen after surgery they also improve. And there is a hypothesis that sodium absorption improves blood sugar. So there are various things, but it has been seen that even before weight loss starts, diabetes gets controlled. So it is not related to weight loss. It is not related to only the diet restriction. So what actually works? Probably all of them. There is no way to know which single factor works to control diabetes after surgery, and all these that I mentioned, they interplay with each other. Now there are various studies. This particular study, which had reviewed about 135,000 patients, had shown diabetes resolution in almost 84% patients. That means they were off medicine and their sugars were controlled. A recent trial, a prospective trial done in US, which is called Stampede trial, which was done at Cleveland Clinic, where they have a group of patients who had bariatric surgery and a group of similar diabetic patients who are managed medically. And they found that after 5 years of starting these therapies, the patients who had a surgery, their HbA1c came down by 2.1%, versus those who were on medical management, where it went down by only 0.3%. A very significant, clinically significant outcome of bariatric surgery in terms of diabetes control. We have also published our data multiple times. And so we had a 3-year follow-up of diabetic patients, where after sleeve gastrectomy, 80% patients have been off medicine for diabetes. And after bypass, after 3 years, 92% patients, almost 92% patients were off medicine for diabetes. And then there was another study we published separately of sleeve gastrectomy alone, which showed at 5 years, the diabetes resolution after sleeve gastrectomy was still 64%. So what does this mean? That means these patients are off medicines for diabetes even after 5 years, and which is a very significant number, because these were all patients who were on high dose of medication and were not able to control their blood sugar. And as Dr. Rushin mentioned about that, it is not an issue of only blood sugar control, but it is also an issue of how diabetes complications get reduced. So there are multiple studies. I'll show you 2 of them. This study has shown at 5 years after metabolic surgery, in non-surgical group, 35% patients had microvascular complication, versus surgical group, which had only 17%. And then there are retinopathies, nephropathies, and neuropathies individually, where there is a significant reduction in the complications of diabetes. There is another study which has shown that macrovascular events reduced by 78%. That means myocardial infarction reduced by 83%, stroke reduced by 75%, and deaths related to diabetes complication reduced by 79%. And then microvascular events reduced by 90%, like blindness reduced by 67%, amputations, which are so common in our country, reduced by 86%, and other vascular events reduced by 83%. And not only that, even heart failures reduced by 86%, and angina in these cases reduced by 78%. So what we need to appreciate is that surgery is not about only blood sugar control, but because of long-term sustained blood sugar control, the diabetes complications which are ghastly and which we are worried about also reduces substantially. Now, as far as Indian guidelines for bariatric surgery is concerned, These are different than Western guidelines, and these are by Obesity Surgery Society of India, where if somebody has 37.5 BMI and has no other disease, person is eligible for surgery. If somebody's BMI is 30 and has significant comorbidity, which could be sleep apnea, hypertension, quality of life issues, or diabetes, the person is qualified for surgery. But if somebody's BMI is only 27.5 and has uncontrolled diabetes, we can still offer this surgery. And this is the most important thing, because 27.5 BMI means about 10 kg overweight. So if your patient is just about 10 kg overweight, the surgery is done only for diabetes, obviously not for weight loss. These people end up losing 5-6 kgs, but nobody loses more than their ideal weight. So this is the importance of diabetes control. There are very few contraindications for surgery. So if somebody is currently using drugs, drug abuse or alcohol abuse, if somebody is uncontrolled psychiatric person, or if that person is not fit for anesthesia, there are very limited contraindications for surgery. And there has been a lot of apprehension about safety of surgery. Now, what Dr. Rushin said and what has changed over years is that now the surgical risk is of bariatric surgery is same to what happens with lap cholecystectomy or a hernia surgery, which is like 0.05% or even less. It is seen that the lower risk is seen in experienced hands at high volume centers, and high volume centers typically 100 surgeries a year. And vitamin and mineral deficiency is seen only in non-compliant patients. Friends, it is identified scientifically what vitamins and minerals patient will not have because of reduced food intake. So if we give them those supplements, they are not likely to have any deficiency as long as patient continues to take those supplements as prescribed by us. Now, as far as diabetes is concerned, predictive factors are called ABCD, and this is a very easy way to understand for physicians. Younger patients have better outcomes. High BMI, that means very heavy patients, have better outcomes. Patients with C-peptide, fasting C-peptide of more than 3 have better outcomes. That means their pancreatic beta cells are working better. And duration, those who have diabetes for short duration will have better outcomes. So this is exactly what Dr. Rishin was saying. Send them early when they are young because they have better results. But let's look at this lady who was 62-year-old when we operated her a few years back. She was diabetic for 25 years, so duration was long. She was on insulin for 10 years. You see about 56 units of insulin. And still her fasting and PP sugars were very high. We offered her surgery in January 18. On the second day of surgery, we had to stop the insulin because sugars went down. And obviously, she lost some weight and sugars are under control, maybe with 1 tablet or 2 tablets of metformin a day now. But that is not the issue. The issue is that her sugar that got controlled and HbA1c came below 7 within 3 months' time. And now, how does diabetes improves? So generally, insulin gets discontinued within a week of surgery, and oral medications in most of the patients stop within 1 to 3 months of surgery. And this is important because you can tell your patients how it is likely to improve in them. Now, how do you assess a patient's suitability for surgery? So one is you can get anti-GAD antibodies done, serum anti-GAD antibodies, and they should be negative. So if they are positive, then patient is probably a type 1 diabetes and should not be offered surgery. Fasting C-peptide should be done and it should be more than 1. This is to assess pancreatic beta cell mass. Higher the C-peptide, better the outcomes. You can do a OGTT with C-peptide to assess responsiveness of beta cells, or you can do a HOMA index. And it's very easy to measure HOMA index because you just need a value of fasting insulin, fasting glucose, and divided by 405. So if it is more than 3, 3 to 5, then the insulin resistance is moderate. And if it is more than 5, then insulin resistance is severe. More severe the insulin resistance, better the surgical outcome. So, beyond diabetes, let me tell you, bariatric surgery improves cardiovascular risk by reduces it by 30%. We have already discussed about diabetes complications. It reduces risk of breast and endometrial cancers. It reverses fatty livers and NAFLD and NASH and even fibrosis in 65% patients. And women with PCOD, the hormone normalizes and fertility improves in almost 100% patients. Those who are on CPAP for sleep apnea, they are off CPAP in almost 93% patients. So bariatric surgery has multiple benefits, and realizing this, central government approved these surgeries for reimbursement of their employees and their families in 2013. Most large corporates in India and in multinationals pay their employees for this surgery for many years. And all insurance companies, Indian insurance companies from October to 2020 are paying for the bariatric surgeries. So, friends, there are now financial issues are really not a big problem. Metabolic surgery is a tool for diabetes control for both physicians and patients, because if you have patients who are not getting control with medicine or are not able to change the lifestyle, bariatric surgery or metabolic surgery can be offered to them. And there is enough evidence to say that these surgeries are safe, efficacious, they reduce complications. And in patients who are long-term diabetic, like this lady I showed you, may require 1 or 2 tablets, but the main part is that they will remain under control. So it's not necessary that we offer this surgery only to youngsters. Even senior people can be offered this surgery. Long-term standing people can be offered surgery. Look at this gentleman who again came from Kenya. He was diabetic, obstructive sleep apnea, severe joint pains, lost almost 75 kgs, half of his weight. And these are the kind of support group meetings that are organized to help our patients understand what we expect from them, and also to support them to make them realize how to maintain their weight and diabetes in long term. So thank you very much for your patient hearing. I'll be happy to answer questions that you can send to Dr. Unnati, or you can directly ask. Thank you so much.
Thank you, Dr. Raman, for that wonderful talk. And the questions have started coming up. So I'll just start reading out the questions to you.
Sure.
The first question is that how are specific bariatric procedures chosen for a patient? Are there criteria for performing a bariatric surgery?
So this has 2 questions. One is, are there criteria for performing bariatric surgery? Yes, them. For diabetic patients, 27.5 BMI is Indian criteria. We can offer them standard bariatric surgeries. Above 30 BMI, if they have other diseases, we can offer them bariatric surgery. And even if they have no disease, then above 35 BMI, we can offer them a bariatric surgery. As far as how do we choose the procedure, there are no standard guidelines to that extent about which procedure to be chosen. No, there are no guidelines worldwide. But in my own practice, what we do is if somebody has diabetes of a long term, maybe 10 years or more, or if somebody is on insulin for 4 years or more, I prefer to do a gastric bypass. Below that, I will offer them a sleeve gastrectomy, but it's ultimately patient's choice, because gastric bypass in long run definitely has better outcomes for diabetes than sleeve, marginally better, but it is there. And in patients who have acidity or reflux disease, we offer only gastric bypass, because in sleeve patients, sleeve is not desirable in these patients. Dr. Unnati?
Yeah, thank you so much, Dr. Raman. I'll just read out the next question to you in a second. Yeah. So the next question that we have is, uh, what all post-surgical changes a diabetic patient could expect in different surgeries like gastric banding, the Rooks and Y gastric bypass, and Bilio pancreatic diversion?
So, Dr. Unnati, gastric bands are no more done. Gastric bands, we have done lots of them between 2000 to 2004, but then it was realized they are not effective either for weight or for diabetes, and they are practically discontinued. So let's not discuss gastric band. Similarly, biliopancreatic diversions are not done in our country because they are malabsorptive procedures, and they are done in Western countries because they are consuming very high amount of proteins through meats. So in our country, we are doing mostly either sleeve gastrectomy or a type of gastric bypass. And what kind of changes one can expect is that within few days, within a day or two, patient's insulin is discontinued. And obviously it is discontinued because sugars become normal. Nobody will discontinue that. So insulin is discontinued very early. Tablets get discontinued within a month's time, most of the time. And their sugar remains within normal limits, fasting PP or HbA1c, for years together. And we know that if sugars remain under control for 1 year, it has major impact on complications. Here we are talking of 5 to 10 years, 15 years, and the sugars are controlled in almost 90% patients. Few of them may require medicines still, like about 30% patients who have been diabetic for a long time, but most of the patients are off medicine, as I showed you in our published data today.
Thank you for the answer, Dr. Raman. And I think I just have the last question for you. Dr. Ram is there with us on the panel. Dr. Ram, do you have any questions for Dr. Raman?
I think he's
not has facing some technical issues. So I have a question from Dr. Mukund Kakde. What are the complications associated with bariatric surgery in geriatric patients with diabetes? I know you have discussed this, but if you could just answer it briefly again, so please. Yeah.
So is he asking bariatric surgery in geriatric patients?
Patients with diabetes.
Okay. So, geriatric patients are actually more compliant as far as I am concerned. My experience goes. These are the people who value their health more than somebody who is very young. I'm not generalizing, but the thing is that these people know that to remain healthy, they must take those vitamins regularly. They must go for a walk every day, and they must follow doctor's advice. So usually we don't have many complications in geriatric patients. They are good patients for us, and they are the ones who are mostly coming with diabetes related complications already there. Some of them had a heart attack in past, some of them have a kidney failure or whatever, and thus they are coming because they do not want repetition of those complications or further worsening of their health issues. And so for me, a geriatric patient, generally we offer this surgery up to 70 years, but sometimes we go up to 75 also if the person is physically healthy. And the only concern is whether they are fit for anesthesia. If they are fit for anesthesia, I am very happy to operate a senior person because for me they are good people, good patients.
Wonderful. Thank you so much, Dr. Raman, for your answers. I think that's all the questions that we have today. Please, Dr.
Unnati, last thing. So to all the family physicians, I would like to say that even if you are doubtful about the surgery, or even if you do not want the surgery to be done on your patients, please do not hesitate to get it done on your own family members if they are diabetic, because this surgery has completely transformed the outcomes of diabetes management and their complications. And just to reinforce, 4 of my own family members, my brothers and niece and brother's wife have undergone this surgery. And that is to say that I believe it can be safely done, has long-term safe outcomes, and can avoid diabetes-related complications, definitely not to the tune of 20%, but to the tune of 70 to 90%. So that is my appeal to you. Wherever you get it done, that's your choice. But bariatric surgery is a good option for diabetic patients in your own family. Thank you.
Thank you so much, Dr. Raman. And very happy to introduce our patient today, Miss Shraddha Saxena. Hi, Miss Saxena. Are you there with us?
Yes, I am. Am I audible?
Hi. Yes, you are.
Okay, great.
Hi, welcome to the program, and we really appreciate you taking out your time and coming and sharing your story with us. So, Ms. Shraddha, can you just introduce yourself to everyone?
Sure. My name is Shraddha Saxena. I'm 49 years old and currently working with TCS as a delivery excellence partner. So, my obesity was from long back. It was not all of a sudden. So, I met Raman Goyal, Dr. Raman Goyal in 2002, wherein I was 95 kgs. But I was too young and never thought of getting the surgery done, but just wanted to know what the technology is, how does it work, and everything. But every patient, like every other patient, even I was, how to do, will I be able to do, should I do, when, what, why, or with all these questions which I had in my mind, I decided not to get into the surgery. And the alarm for me was in 2016 when I got diabetic. I have a family history of diabetes. My dad was diabetic. My brother is diabetic currently. So that's the time when I decided that no, I should get rid of not only the diabetes, but I should concentrate on my health also. At that point of time, my health condition was quite critical, but I was just ignoring it. Ignoring only when my yearly checkup came up and I saw that I'm diabetic, that's the time when I realized that I should get in touch with a good doctor to get all the resolutions done. So that point of time, my weight was 147. And when I met Dr. Raman Goyal, there is a checklist which he follows. So categorizing each and everything, I came to know I had gallstones. Then I came to know I was obese, no doubt, which I was ignoring since a very long time. Then I came to know that my pressures were not at all normal. They used to be 85. I was diabetic. I had sleep apnea when there was the checklist which was done prior to the surgery. And I was refused for the surgery. I was refused for the surgery because I had to get a lot of things resolved. And then that technicalities, definitely all of you doctors know that to get operated, you need to be optimized. So it took a long time for me to take a decision also and for the technical things to be optimized and then get operated. After getting operated, my lifestyle changed drastically. The weight loss was happening every month. A suggestion from my end would be the surgery happens for 2 hours, 3 hours, but the maintenance program and even the weight loss will definitely happen because the doctors have done their task. But then when the maintenance part comes, it is us who has to follow up and dedicatedly do that, for which CMS especially. There would be so many doctors across, you can go anywhere and get it done. But when we have CMS as goalkeepers meetings, wherein you just feel like a family, you can contribute your views, you can contribute your ideas, you can take ideas from others. It's like a sharing best learning practices from each and every one. and we don't have communication gap with any of the team members. That's the best thing, which I think that I'm comfortable with, and which is giving a significance role to my weight loss journey. So even if I put on today's 2 kgs, I know for the fact that tomorrow I will bring it down anyhow. So the follow-up and the maintenance is the key factor in this kind of surgeries. The surgery will definitely happen with a time frame of 1 year, 2 years. Your weight loss will also happen. But after that, the follow-up and the maintenance is definitely to be done. That's all from my end.
Thank you so much. I think we
Medicine.
understood. I think we couldn't agree more. Ma'am, I would just request you to put your could you just lower your camera a little? We are losing half of your face here. Yeah. Thank you so much. Yeah, that's much better. And I would like to congratulate you and appreciate your effort, whatever you have done to, take care of your health. And I just have a couple of questions for you. So, apart from you told that you had diabetes. So, apart from that, what lifestyle issues you had before getting the surgery done, and how did that change post the surgery?
I was quite lazy. I never used to walk down. Walking up the steps, I never had done. I stay on the first floor. I never used to pick up this. I never used to walk the steps. Second, laziness was sitting in the car itself and ordering food, which would be vegetables or something, because it was not convenient for me to go to the market and come. So just doing all that stuff. Today, I can walk up to 2 kilometers a day. Even if it is on a ramp road, it's not a straight road, I can do that. I have been practicing it also. So that's the kind of lifestyle. I don't have any breathlessness issues. Previously, even if I used to walk down inside the house, I used to have breathlessness issues. So that is definitely a drastic change after the surgery.
Drastic change. Great. And like you, of course, how was your psychological experience after? How was like the support from family? How much does it matter? Support from your family and colleagues.
It matters a lot, but very grateful for my family who understands me more than me. They used to sit and decide what I have to eat and how much I have to eat. Across the room where I have my snack center inside the kitchen, my brother had just painted few things for me to remember that I don't have to do this. Small things like eating your multivitamins. There were stick boards on my study table everywhere, because that is something which I don't remember. Honestly, till date, I don't remember to take my multivitamins. When I'm sitting on the desk, now it's work from home, I don't even remember to get up to drink water. So sticking all these pointers somewhere across the house definitely matters a lot. Keeping reminders on the mobile phone, that also helped me a lot.
Great. Again, thank you so much for being a part of our program. I'm sure your testimonial would inspire a lot of people, lot of our doctors to counsel their patients. And keep up the good work, ma'am. Thank you for being here again. Dr. Raman, do you have anything to say?
Yeah. So, Dr. Unnati, as far as Shraddha Saxena is concerned, she has been one of our favorite patients.
First patient, sir.
And she had a very tough time before surgery to be prepared for surgery. I am fully aware of what she's saying. She is saying less actually, but she had really tough time to get prepared for surgery. And these are planned surgeries, so there was no question of taking risk and doing it. And but she had been an excellent person after once the surgery was done. She transformed her life, and she's like a family for us now. So many times we interact beyond surgical issues. And I have a question for her though. So Shraddha, how is your blood sugar control? You said you had this diabetes before surgery. Now, how many years you're done after surgery?
I don't remember after the surgery I've ever taken medicines. And I was never ever diabetic after the surgery. I came out of the operation theater, and after that, I've never ever taken any medicines.
Okay.
And
And do you check your sugar once a year or
yes,
sometime? Yeah.
once a month, because diabetes is something which is we always have heard in our past since childhood that if you are diabetic, you can get prone to that condition again and again. So once a month I do that, and it's always normal.
Yeah. So I think that this is such an important message that people believe that because surgery is done, then the sugars will come back or weight will come back. And in compliant people, Shraddha is a very senior executive person, very highly educated. In compliant people, the outcomes could be really, really very good, and that's so important. So thank you so much, Shraddha. And how was your weight loss overall? In last so many years, are you able to maintain it?
We did the surgery in 2017, 18th of December. Initially, it was drastically done, but in comparison to other patients which you had, sir, my weight loss was quite slow, which I was very much bothered about. But you and ma'am were quite supportive, and definitely I reached up to 78. That was last year, 2020 April. Then I put on till 82, and today again I'm 82. So it's constant.
Excellent. That's wonderful.
Wonderful. Thank you for sharing that. And I think it's an inspiration. And I think it will help develop confidence in a lot of doctors first, and then they will pass on this confidence to their patients. I think Dr. Raman would agree here.
Absolutely, Shraddha. Thank you so much for coming.
Thank you, Ms. Shraddha.
You have done so well, losing almost 60 kg weight and maintaining your blood sugar so well after surgery.
Yeah, I remember that you all had given me a target below that, but I'm not able to achieve it. Let's see. I might try to do
I
it.
think you're doing very well, and that's more what is required. So thank you, Dr. Unnati. Please, are there no more questions? Dr. Ramkumar,
Dr. Raman, thank you. It was a wonderful session.